All right, good afternoon, everyone. Thanks for joining us today for the May installment of our Age-Friendly Public Health System Training Program. My name is Megan Wolf, and I am a Senior Policy Development Manager at Trust for America's Health, or TIFA. I'm joined today by my colleagues, Dr. Karan Phillips, Dr. Jeanette Kowalik, who are both on our policy development team, and by Cecilia Thomas, who's on our government relations team. I think most of you by now are familiar with Zoom, so please keep your microphones muted unless you're participating in the discussion or asking a question. And please feel free to use the chat function to offer comments, share resources, or ask questions. Next slide, please. So I'm sure most of you are already familiar with TIFA as well, so I'm going to forego the TIFA introduction today so we can dive right into our discussion. Today we'll be walking through the Guide to Innovative Practices that was created as a result of TIFA's project to explore the challenges and solutions to ensuring access to the COVID-19 vaccine for those who are homebound. And this project was generously funded by the John A. Hartford Foundation and the Cambia Health Foundation. We hope to facilitate discussion about the guide and its contents today, as well as answer your questions. We want this to be a little bit more of an interactive session so that you can get as much out of it as possible. So after we talk about the guide, my colleague Cecilia will join us to talk about the current state of vaccine hesitancy among older adults and share some recommendations from a brief that TIFA published earlier this year on building vaccine trust in and access to the COVID-19 vaccine within communities of color and tribal nations. Then we'll have another period of discussion. Next slide, please. So I like to show this next slide. This is a CDC slide that clearly shows the risk of serious illness due to COVID-19 the older we are. These numbers are staggering, showing that adults 65 to 74 are 5 times more likely to be hospitalized and 90 times more likely to die if hospitalized for COVID-19. And for adults 85 years and older, they are 13 times more likely to be hospitalized and 630 times more likely to die if hospitalized for COVID-19 compared to younger adults. These are absolutely shocking numbers and point to the crucial need to ensure all older adults are fully vaccinated. But when it comes to people who are homebound, vaccination becomes complex and challenging, and there's no national strategy nor equal implementation across states and local jurisdictions to ensure access for these individuals and their caregivers. Next slide, please. Dr. Terry Fulmer, president of the John A. Hartford Foundation, first brought this issue to TIFA's attention and provided additional support for us to identify the challenges, raise the visibility of these issues with key stakeholders, and develop policy recommendations and additional tools, not just to address the issue, but hopefully to really impact people's lives. And that's what we are all about here within public health with the Aging Network and community health organizations. So TIFA quickly brought together federal, state, and local policy leaders, national stakeholder organizations, and others in 2 national convenings, a national webinar, and a series of short huddle calls. Working with a public health consulting firm, Ripple Effect, we conducted numerous interviews and performed literature and internet searches. Next slide, please. The issues that emerged were categorized into these 9 themes. And although now, of course, the vaccine supply issue has been mostly resolved for the majority of the US population, ensuring access to the vaccine for the homebound remains complicated, including identifying those in need, addressing hesitancy issues, expanding that pool of vaccinators, and ensuring all of the different costs, administrative, travel costs, and so forth are reimbursed. Next slide, please. So TIFA developed a set of 9 policy recommendations that are available in great detail in our recently published brief. And you can see in this graphic that there is a logical flow of the recommendations and that each one has a targeted leader or leaders based on the legend in the upper right section of the graphic. These include defining who may be considered homebound, identifying data sources, promoting flexibility and creativity in vaccine distribution and access, and so forth. And we'll make sure that we post a link to our website in the chat so that you can access this policy brief as well. Next slide, please. So in addition to the brief and with the help of our consultant partners at Ripple Effect, TIFA also created a guide to innovative practices on in-home vaccinations that was really the brainchild of one of TIFA's board members, Dr. David Fleming, who you will hear from in just a moment. The guide contains detailed descriptions of actual strategies, programs, and plans being implemented by health departments, home-based care organizations and agencies, community organizations, and many others. And it's categorized the way you see it laid out on the bottom of the slide here. So I'm going to be providing further detail about some of these categories, and then we're going to go online together to explore the guide. So next slide, and Karan, if you would please now play David's video, I'd appreciate that.
Hi, and good afternoon. My name is David Fleming, and I'm a visiting fellow at the Trust for America's Health. For the past couple of months, I've had the really good fortune of being able to work with TIFA and Ripple Effect on this project. Megan asked me to do a quick introduction to the guide for best practices that you're all going to be talking about today. Apologies for doing this as a video. The stars didn't align, and I had a long-planned other commitment at exactly the same time. It's interesting. So Megan's already briefly outlined the overall project, which was to think about the challenge of immunizing people who are homebound with COVID vaccine, and being able to work with TIFA and Ripple Effect on this project. Megan asked me to do a quick introduction to the guide for best practices that you're all going to be talking about today. Apologies for doing this as a video. The stars didn't align, and I had a long-planned other commitment at exactly the same time, although far less interesting than this one. So Megan's already briefly outlined the overall project, which was to think about the challenge of immunizing people who are homebound with COVID vaccine, and to develop a set of recommendations to help advance this work, and to recognize that this critically important need was arising at a time when issues of equity had never been so stark, and our public health and clinical healthcare delivery system had been stretched to breaking. So the process used by the team was basically to conduct interviews with practitioners of public health who had already started on this work, with state and local public health agency staff, with home-based primary care providers, national stakeholder organizations, and others. We also sought input from appropriate federal agencies and conducted both peer review and gray literature review. My background is in public health, including being lucky enough to have worked with and for state and local public health agencies in my past. And maybe like some of you, I didn't have a lot of experience in dealing directly with providing services to people who are homebound. But being a practitioner in local public health, I've often had that experience of not being the expert and facing a job where there hasn't been a lot of work or a clear template. And so I know there's not a cookie cutter approach here. There's no one right answer because every place is different. But that doesn't mean that everyone needs to start from scratch. So that's what this guide is. Basically, it's a compilation of some of the clever ways that people are solving this problem in their jurisdictions to give the rest of us ideas about approaches we might consider in our jurisdictions. There were 4 issues that most everyone was confronting. First, because this is multi-sectoral, roles and responsibilities, figuring out who's in the lead and what are the responsibilities of the different agencies that are going to participate. The second was figuring out who is homebound, finding out who those individuals are, who's in need, and how to get a hold of them, both by using existing data sources and by providing mechanisms whereby folks who are homebound or their caretakers can directly contact us seeking a vaccination. The third was basically figuring out the mechanics of how to do this work, how to get vaccine logistics in order, how to array staff, how to do something that really hasn't been done before, and that's very labor intensive. And then finally was identifying the resources. This is not cheap to do on a per person basis, and looking around and finding clever and innovative ways to finance this from both a financial and human resource perspective. What we tried to do is to array approaches that implementers had taken in each of these 4 areas to hopefully spark your own creativity. And I hope you find this guide and this webinar useful. So thanks so much for letting me briefly join the meeting in this way to give you some of that perspective. And I'll now turn it back over to Megan.
Great, thank you. And we're so appreciative of David's engagement and involvement. He's brought so much great perspective, but also expertise and really wisdom to this effort. So next slide, please, Karan.
Hi.
So the first thing that we want you to understand is how the guide is laid out, organized according to these 8 sections. And so once we go online and you'll be able to see it, but once you find the section that you are most interested in, you click on it and it will immediately jump down to that section of the guide and identify those, as David said, clever and innovative practices and programs that different jurisdictions have been implementing. So next slide, please. Let's look at the first one. We're going to start with leadership. As David mentioned, it's really important to identify who's in charge of this effort. Governments at all levels share responsibility between public health, healthcare organizations, community partners, and so forth. There needs to be a shared responsibility. Significant additional planning is needed to operationalize a huge vaccination response like this to COVID-19, which is much larger in scope and complexity than your seasonal influenza or other previous vaccination responses. So that defined leadership is necessary for preparation, implementation, and particularly for accountability. So the example that I'm showing here on the screen today is from the Illinois vaccination plan. They include a section on organizational structure and partner involvement. You can't read it from on this slide because it's very complex, but you can go. There is a link to the Illinois plan within the guide, so you can jump to it, take a look at this chart that does show the complicated nature of the process, but also goes to the importance of having leadership in place to oversee all the planning and coordination. And our guide includes many other examples, including CDC's operational guidance. Next slide, please. The next section is on the important topic of defining which individuals may be included in this population, which is crucial for planning for distribution, planning for vaccine allocation, and how many vaccinators a jurisdiction may need, among many other considerations. So you can see here on the slide, the Medicare definition is that someone is considered homebound if they need the help of another person or medical equipment, such as crutches, a walker, or a wheelchair to leave their home, or their doctor believes that their health or illness could get worse if they leave their home, and it's difficult for them to leave their home and they typically cannot do so. Now, some jurisdictions are using this definition. Some of your jurisdictions have created their own definitions, which is completely appropriate. Some are broader, some are more narrow, that it's just important to be able to identify, create a definition so that you know where to go and who can be considered homebound. And we believe that although not officially part of the definition, caregivers of those who are homebound, both paid and unpaid, should be included in vaccination distribution and allocation for those who are homebound. There are also multiple sources and networks who can help to identify the homebound. One important consideration is also whether, if some of these individuals are supported with accessible transportation, can they actually get to the vaccination site? And that would reduce the need for the incredible amount of resources that it takes to ensure that all homebound people are vaccinated. Next slide, please. Another crucial aspect of getting the vaccine to the homebound is addressing equity and ensuring equitable access. Current data show that Black and Brown individuals are not getting vaccinated at the same rate as white people, and this simply exacerbates the disproportionate burden that COVID has already had on communities of color. Some jurisdictions are using what's called a social vulnerability index for allocation decisions that take into account things like socioeconomic determinants, disability, and race, ethnicity, and language. So our example here is from Philadelphia. You can see the map of Philadelphia, where they were able to really focus in on addressing disparities, including identifying persons with high-risk medical conditions who are more likely to be in racial and ethnic minority groups, allocating vaccines initially to the Rite Aid pharmacies, which, at least in Philadelphia, have the greatest percentage of its stores in minority neighborhoods. providing vaccines to and supporting federally qualified health centers and other clinics that serve low-income minority populations, providing vaccines to the Black Doctors COVID-19 Consortium, which is an organization with a strong focus on reaching African Americans. So you can see that the Philadelphia response was very thoughtful and very focused and prioritized equitable access. And again, the link to the Philadelphia plan is in our guide. And next slide, please. The last example I'm going to share before we actually go to the guide is about reimbursement and costs. We know that it's much more expensive to administer in-home vaccinations because of the transportation, the individual attention, added observation time, and potential waste of vaccine doses if others in a household are not given the vaccine or there's just not enough people in the household to use them up. So there are options for coverage, including those you see on the slide. A lot of those federal COVID-19 relief packages, some of that funding can be used for coverage. Of course, Medicare and Medicaid, FEMA has some funding, and of course, and commercial payers and insurers. So early on, Massachusetts recognized the need to increase reimbursement rates. So they established their rate at $100 for each first shot given, which was far and above the original federal reimbursement rate, which I think was like $28 or something like that. Initially, and then went up to $40. But so Massachusetts provided a reimbursement at $100 for the first shot in home and an additional $20.40 for each additional vaccine in the home. So really kind of had a lot of foresight in terms of what was going to be required to make sure that that was fully covered. Okay, we can go to the next slide. And Karan, at this point, we also can go online to the actual guide. And folks, this is where we really would like for you to join in and participate with us as we delve into this guide. So I want to go, Karan, if you'll first, you can see, folks, you can see on the bottom all the different categories, those 8 categories of how the guide is organized. And Karan, if you'll click on the first one, leadership for organizing the effort. So once you click on that, it takes you right to that section. And as I mentioned earlier, one of the first ones that we looked at was the Illinois Department of Health. So we've embedded links to many, as many as we had of the different strategies and plans within the guide. So Karan, I don't know if we can click on that and then be able to come back to the guide. If you can click on that Illinois Department of Health link. Great. So see, well, this takes you right to the resources. We've tried to make it, this as usable and as easily usable as possible for you all. Okay, go back to the guide for me. And then let's go to one of the categories that we did not look at. How about expand and diversify the vaccinator pool? There we go. So again, here are some different strategies using emergency medical personnel. On the left, you'll see what the strategy is. In the middle, where it has been done, and in the right, some notes about it, including retired nurses as vaccinators, including hospice nurses as vaccinators, using CARES representatives as vaccinators. So again, links where we have them. We also will be adding to this guide as we learn about different resources. So we want this to be a very dynamic resource for all of you. If you have ideas, or if your jurisdiction has implementation plans and strategies that you would like to share with us that we can include with the guide, we would love to have them. You can email, Karan, would you put the AFPHS email in the chat? You can email us at afphs.org, and we will continue to collect those strategies and plans and include them in our guide. And I believe Karan also just put the link to the guide in the chat for you all as well. So I wanted to just open this up a little bit for some discussion at this point, see if anyone has a question, or if there's something specific you'd like to look at in the guide. We can actually do that now if you're interested in doing that. So Karan, why don't you jump back up to the beginning of the guide, how it's organized, and please feel free to unmute yourself and identify yourself and ask a question or offer a suggestion or start the discussion. And thank you, Marcy, for your comment about making the guide user-friendly. That was a lot of David Fleming's work in working in very close partnership with Ripple Effect and our friends at Ripple Effect. So I'm really happy that that you're finding it useful. Any other questions or suggestions? Does anybody have ideas for adding to any areas of innovative practice as well? Are there areas that you're still struggling with?
Hi, this is Kara Hinckley with Louisiana Department of Health Immunization Team. I have a question for you all, and then also anyone else on the call. With getting the in-home vaccine registry up and going, we're in our 5th week, and we have about 180 individuals who have registered, and this is statewide, with the exception of New Orleans, because they have their own health department with their own vaccine program. And last I heard, they had done like 190 vaccinations in home. So my question is, we've seen that slow down, the registration slow down quite a bit. I'm curious if, and I haven't had a chance to look over your guide yet, but I'm curious if others are seeing the same thing. And I'm also curious if folks are considering opening up the eligibility to include folks who are requesting in-home because they lack transportation.
That's a great, great comment and great question, Kara. And you know, I think that there has been a bit of a slowdown in registrations and in interest. We don't know quite, you know, I mean, there are a number of factors, right, for that most likely. But I think that opening up the eligibility to more people would certainly help to get the vaccine out there. Are you asking to open, are you asking if other jurisdictions are expanding eligibility to include people who can get out of the home, but just would prefer an in-home vaccination? Is that the category of people that you're referring to?
Correct. You know, as we've seen demand sort of plateau a bit in some areas, we've been discussing, and we have a transportation call next week, and we're going to talk about this a little more, discussing opening up, exactly as you said, to folks who they are not considered homebound, but they would like to have the vaccine in home. So I know Delaware has done some of this, and then Florida and a number of counties has done this. So we're discussing it. Yeah.
I am not aware specifically of other jurisdictions that have done that. I think it makes sense. It might be a little bit more expensive, right? So I understand why there may be a little bit of hesitancy in doing that. But if you have, so you said that Delaware and some of the counties in Florida are doing that. So we will look.
Yes, that's correct.
We'll look into that. Thank you. And Kathy Bay.
Hi, I'm from Washington State, and we actually, it depends on our local health jurisdiction, but we actually took a broader sweep in most counties and really focused on the idea that if someone is unable to access for whatever reason, and sometimes there can be mental health issues and other medical issues that can make it difficult for people to get out, even if they're not technically considered homebound. So in most of our local health areas, it really is, we would prefer to be able to vaccinate as many people as possible, knowing that those folks interface with others, and it helps us overall. So in most of our locations, we've just taken a broader sweep that if someone's requesting support, that we would actually provide it no matter.
That's great, Kathy. Thank you.
Megan, there are a few questions in the chat for us. All
right. You want to pose those questions for us, Karan? Because I'm not
Sure.
looking at those right now.
Several questions at once. So let's see. How to reach multi-generational households in priority areas. And then I'll address, I think, the second piece, but the third piece is any examples utilizing community health workers for reaching homebound.
Right. So I think that there are a number of strategies here. I'm trying to think where to go for the answer. So for multi-generational households, I think that that's could be under vaccine supply and equitable access. Having a plan for leftover doses. Keep going, scrolling down a little bit. Right, so probably not the right category. We don't have that that actual question, but we will. So as Ajar, I'm not sure how to pronounce your name, but we will definitely look into that and make sure that that is clear, or if we have additional places and ideas for multi-generational households, we definitely will include that. And that might be an interesting new category to add to our key areas of innovative practice. So thank you for that question. I do see also the question here about whether the guide has been translated, and it has not been translated, but again, appreciate that suggestion, and we will definitely look into that as well. Community health workers, yes, I think community health workers have been involved. They've been a crucial aspect for getting because they are some of the trusted people, right, that can go into the home and talk about hesitancy as well as potentially becoming vaccinators themselves. So I think that the community health worker population or profession have definitely been tapped into in a number of jurisdictions. Great, thank you, Ashar. Other questions, thoughts, ideas? You guys have given us a lot of good ideas and suggestions here today, so we really appreciate that.
Megan, this is Jane Carmody, and I'm with the John A. Hartford Foundation, and I was just intrigued by the question about community health workers. I remembered that there was quite a bit of conversation about people that would be able to actually give a vaccine, recognizing you would be fairly independent in the home, and recognizing that you're really watching for that reaction potential, which doesn't happen very often, but that you would want to make sure somebody was maybe more of a clinician that was in the home, but the community health worker, of course, would be part of the team or working in other ways. So I just wanted to talk a little bit if anybody's thinking about actually a community health worker that would actually be giving the vaccine.
Thank you, Jane. Appreciate that comment. Karan, can we jump down to the expand and diversify the vaccinator pool and just take a look at that section really quick? So we do have folks using EMS and EMT, retired nurses, hospice nurses. Scroll down again for me if you would. Native language speakers, National Guard, CDC requires training and identifying the pool. So yeah, so interesting. We don't actually have specific suggestions or implementation strategies that include community health workers, but I do feel like that is happening in some places. So we will look into that and see if we can include those in this guide, and also kind of identify what the challenges are, right, to using the community health workers and how to overcome some of those challenges.
And Elizabeth, just sent a note about what they're doing in teens, so that's helpful too. Megan, I think that's a great idea, and thank you.
Yep, thank you, Jane.
Megan, can you scroll up to slide 10? In Louisiana, we use contracted strike teams. And I was just looking to see if those were.
So that's Kara. I'm sorry, you were saying.
Yeah, so we use contracted strike teams so that we have 7 different organizations that we have contracted with to provide in-home vaccine across the state.
And that's who we use for our in-home.
Great, thank you. Now, I know there have been a lot of interesting strategies used. I know that when we were talking to our colleagues in Seattle, King County Public Health, that they also were talking about using dental students and medical students and even public health, diverting some medical students into public health so that they could get them trained to do vaccinations. Veterinarians, a number of different types of healthcare professionals that may not be traditional vaccinators, but really thinking creatively and innovatively about who are the people that could do this, could become vaccinators, and who would be willing to step into this role to ensure that the homebound population can be covered. So we appreciate all those suggestions and recommendations. Any other thoughts before we move on? Great, thank you everyone very much. We do appreciate all the suggestions. We will take them to heart and do the best we can to get them incorporated or respond to your additional questions and thoughts. So Karan, I think we can go back to our slideshow and go to the next slide. And we will invite our colleague, Cecilia Thomas, who is on TIFA's government relations team, to come and talk to us a little bit about vaccine hesitancy, but also some strategies to address vaccine hesitancy among older adults and communities of color. So Cece, turning it over to you.
Hello, everyone. Can everyone hear me?
Yeah.
Okay, great. So I'm not going to take too much of your time today, but I do want to kind of follow up on what Megan has been discussing and discuss vaccine hesitancy as it relates to older adults, but really as in general and how the intersections of communities are seeing vaccine hesitancy play out in different ways. So as a level set, I'm going to give the current state of vaccine hesitancy as it relates to the COVID-19 vaccine, how lack of access is oftentimes being misinterpreted as hesitancy in some communities. And finally, I'll share the TIFA recommendations on how to lessen vaccine hesitancy today and beyond the pandemic. So, based on recent polling, vaccine hesitancy is thankfully waning nationwide. So finally, some good news I can bring to you. According to the most recent Axios poll, 67% of American adults have either gotten a COVID vaccine or will get it as soon as possible. The same poll shows on a separate yet rephrased question that 75% of respondents said they either had gotten the vaccine or were likely to get it. Both of these responses were at an all-time high. This is a shift from the more concerning data from the previous month, when every day from April 14th through May 9th saw fewer people receiving a first dose of COVID-19 vaccine than 7 days previously, according to the CDC. The polling data also seemed to indicate a stall in people wanting a vaccine during the month of April. I'm sure that many of us heard that in April, things had started to slow down, which caused a great deal of concern. However, at the beginning of this month, more people received a first dose than on the previous Monday. This uptake also followed up on Tuesday with more people getting a first dose than on the prior Tuesday, and so on and so forth. From that Sunday to Wednesday time period, and this was before the 12 to 15-year-olds officially became eligible for one of the vaccines, the US had gained about 87,000 vaccinations compared to the rate over the same period from the week before. What's also encouraging is that the current rate of vaccination can be categorized as overall solid. So we're on the right track. For example, when President Biden set a goal for 70% of adults to receive at least one dose by July 4th, at that point, a little over 56% of adults had received the vaccine. As of this past Saturday evening, nearly 60% of adults had at least been partially vaccinated. Next slide. So the question becomes, who is actually more hesitant in receiving the COVID-19 vaccine at this point? So in the months leading up to the vaccine's distribution, there was a great deal of talk about communities of color, specifically the African American and Hispanic communities, being the most hesitant groups to take the vaccine, and the outreach efforts that were going to be needed to create confidence. But that has not turned out to be the case. Maybe in the beginning, obviously, there was more hesitancy because we didn't have it yet. But as time has gone on, we've seen a very different narrative. As the slide demonstrates, just making sure it's the right. As the slide demonstrates, almost half of Hispanic adults report receiving the COVID-19 vaccine, with 1 in 6 wanting to as soon as possible, but not having the opportunity, which we will get to a little later on. Actually, only 9% say they are definitely not receiving the vaccine, which is less than both white and Black respondents. Also, Hispanic adults seem to be the most enthusiastic of each of the racial groups surveyed to get the vaccine sooner rather than later. Next slide. In addition, Hispanic adults are more likely than white and Black adults to report getting vaccinated at community health clinics, which we will discuss in the recommendation portion of the presentation, but I think it's important to note that this shows the importance of community health centers for not only the Hispanic community, but pretty much any minority group, but especially the minority groups where language, technological issues, and other barriers may exist. Next slide. So polling done by the National Urban League and the Alliance of National Psychological Association for Racial and Ethnic Equity conducted last month confirmed the increased amount of vaccine confidence among more racial minority groups. This data shows that huge majorities of all the groups surveyed are willing to take the vaccine. For example, 67% of Black Americans, 71% of Latinos, 81% of Filipino Americans, 90% of Vietnamese Americans, and 66% of Native Hawaiians say they will get the vaccine when it's available to them. Also, just to show that the trend has been following suit as the months go on, a poll conducted this month by the Kaiser Family Foundation noted that 55% of Black adults said they have been vaccinated or plan to be soon, which is up 14 percentage points from February. Those rates are also 61% for Hispanics and 64% for white Americans. Now let's compare this data with several polls and anecdotal evidence, namely the Civics Poll conducted in April, that cites that vaccine hesitancy is higher among white Americans than any other demographic, and that data has remained consistent into the month of May. Therefore, white Americans are now less likely than Black, Latino, and Asian Americans to make a plan to get the vaccine. Next slide, please. Sorry, my computer froze. All right, so COVID access for communities of color is now something that we need to take a look at, considering that the data surrounding who exactly is hesitant to take the vaccine would now lead us to ask, why are many of these communities receiving the COVID-19 vaccine at a much lesser rate than their white counterparts? Well, the answer is less hesitancy and more access. Anyone who has received the vaccine or is waiting to receive it, especially in the beginning months of this year, knows that this process has had many barriers for everyone, but has been more so for underserved communities. For example, while 8 in 10 white Americans own a computer, fewer than 60% of Black and Latinos do, and many vaccine websites aren't optimized for mobile web browsers. In addition, the lack of personal transportation and inflexible schedules can also create barriers, particularly for low-income and frontline workers. As we are aware, many of us have had the privilege to work from home, but everyone can't sit at their computers at 9 a.m. refreshing a website trying to get a vaccine appointment. That is not everybody's reality. So those are all the reasons why, those are just some of the reasons why multiple cities report seeing white residents booking vaccine appointments at clinics located in communities of color. So moving on past a little bit past the access issue, it's important to see how vaccine hesitancy and access issues can go hand in hand at times. So even though we are seeing that access has become more of a factor than hesitancy in the COVID-19 vaccine distribution, it does not mean that deep-rooted hesitancy is no longer an issue. So it should come as no surprise that communities of color have less trust in the pharmaceutical industry and the American healthcare industry as a whole. For centuries, medical researchers and practitioners experimented on patients of color without their consent. I don't have to go into most detail about this, but the most famous example would be the Tuskegee experiment, which misled poor Black men in Alabama into believing they were being treated for syphilis, while researchers were merely keeping tabs on them until they died so their body could be autopsied. Even after discovery of penicillin, U.S. Public Health Service doctors and nurses administered only aspirin and placebos to Black people. This case only scratches the surface of the medical bias that Black and Brown communities have faced historically and continue to face today. Now that we have talked about the history of hesitancy and access issues as it relates to the COVID-19 pandemic, let's explore how these issues are linked. It's very hard to have confidence in vaccines that you don't have access to. And people of color are more likely to be uninsured and have less access to healthcare. And when they do see a doctor, they often receive worse care than white people across significant percentage of healthcare quality measures. As a result, the significant distrust of the medical profession in communities of color is real and pervasive through generations due to explicit and implicit discrimination. Next slide, please. So we know that older adults of all races have been disproportionately impacted by this pandemic, but that does not mean that hesitancy is still not a pervasive factor with this subset of the population. As I've discussed, there are various racial groups that experience hesitancy, and obviously older adults fall into each one of these groups. This slide breaks down the vaccination rates of adults 65 and older by census region, economic standing, and the social vulnerability index. We see that overall 70% of adults 65 and over have been vaccinated, which is very positive, but clearly there is more work to be done in that area. This slide outlines the improving vaccine acceptance amongst this population. The hesitancy issues still remain, with AARP studies showing that 40% of older adults are concerned about vaccine side effects. 26% were concerned about the vaccine's effectiveness, while 32% believe that they're in good health and simply don't need the vaccine at all. This is not a surprise considering the information I gave earlier regarding the different racial groups and their hesitancy, and also older adults. They tend to have more chronic issues, so that those are legitimate and valid questions, but we definitely need to increase the amount of older adults that are being vaccinated and deal with their hesitancy issues as well. So now that we know the problem, it's time to discuss solutions to vaccine hesitancy and access issues in communities of color and otherwise. Next slide. So in October of last year, TIFA co-hosted a national convening on vaccine hesitancy in communities of color in coordination with the National Medical Association and UNIDOS US. This led to a policy brief with recommendations that was released in December. While these recommendations were most immediately applicable to the COVID-19 vaccine, these recommendations will go beyond the pandemic and will be important in gaining vaccine trust in these communities into the future. The convening created recommendations for policy actions that should be taken immediately within 6 key areas. Next slide. The first, ensure the scientific fidelity of the vaccine development process. People need to know how the vaccine was developed and the guardrails that were set up to make sure that it is safe once it's time for distribution. Now, granted, that is also very scientific and very specific, but what people really need to know is what is happening, when it's happening, and really feel like they're part of the process, as opposed to scientists or whoever coming out when it's time to distribute it and saying, here, this is what you need. You have to build trust much sooner than that. Second, equip trusted organizations and networks within communities of color and tribal communities to participate in vaccination planning, education, delivery, and administration. Ensure their meaningful engagement and participation by providing funding. Many of the issues that took place at the beginning of this distribution revolved around a lack of funding in many communities because they did not have the resources to store the vaccine in a very cold area. They didn't have the manpower to administer the vaccines. This all goes back to funding and making sure that all of this engagement is being done well before it's time to distribute vaccines. Next, provide communities the information they need to understand the vaccine, make informed decisions, and deliver messages through trusted messengers and pathways. This would require working with local doctors, pharmacists, and religious leaders, etc., to get the needed message out to the target community. There are many examples of that working to lessen the hesitancy during the COVID-19 vaccine distribution effort. Next slide. Next, ensure that it's easy as possible for people to be vaccinated. That means eliminating all barriers, whether it be financial, location, technological, or language. Know the needs of the community being served and address them prior to the vaccine distribution. Next, ensure complete coverage of costs associated with the vaccine incurred by individuals, providers of the vaccine, and state and local, tribal, territorial governments responsible for administering the vaccine and communicating with their communities about it. We have to make sure that Medicare and Medicaid are covering the majority of the costs for these vaccines so as not to be another barrier. And finally, Congress must provide additional funding and require disaggregated data collection and reporting by age, race, ethnicity, and other demographic factors on a variety of issues that include hesitancy and access, so that state and federal agencies can know where the problem areas are and can create solutions. I want to thank everyone for joining me today and listening to what I have to say about vaccine hesitancy, and I look forward to a robust discussion. Thank you.
Great, thank you so much, Cece. Some really great information. Really appreciate highlighting the data, the changes in the data, as well as the recommendations in the brief. So, Karan, you want to go to the next slide, please? And so we want to again open up now for questions, but not just questions, also discussion. And there's already been some really good discussion going on in the chat section. So if anybody would like to come off of mute and kind of reiterate some of the questions that or the comments that you've made in the chat. I know Elizabeth, that you've posted some interesting information, and then Kim, I believe, Kim Boone also was talking about some of the information on the KFF website. So if either one of you would like to unmute, or others who may have questions.
This is Kim Boone, and I was following up on, I think Annette asked a question about Native American, Alaska Native information. And so I followed up. I went to the Kaiser family website link that you provided. Thank you very much for that. And just noticed that they said that there was a lack of information for certain communities. But at the same time, there was an article that they developed and created about vaccinations in Native American, Alaska Native communities. So I put that link in the chat, and so I just wanted to make. I'm interested in that topic, and I thought others might be as well.
Great, thank you so much for finding that and including that in our record here. We'll save all the chat information as well, and we'll be able to provide that as part of our resources for this training session. Cece, I know I'm kind of putting you on the spot, but in terms of the American Indian Alaska Native people and data, is there anything that we learned in the convening last year about these populations and accessible data, or anything that might be helpful to this audience?
So what we did learn is that when we're talking about Alaska Natives and Native American community, there is not a lot of data because much of their work is internal, if that makes sense. So like they've done a really wonderful job in terms of getting like various tribes vaccinated, because it's all community leaders. So, you know, they're not tending to have, or they have less access to like high-speed internet and some of the things that, you know, we're always kind of taking for granted. So it was all community leadership. It was all word of mouth. So there isn't a ton of data, but what I can do is I do know some folks who have worked, especially in Alaska. I was on a panel with one, so I can get some of that information to you probably much quicker than I thought. So I just kind of looked it up and it was right there. So I do have that. I have some slides if you want to like distribute those from one of the panelists I was with. So I think that could probably be a little bit more helpful.
That would be great. Thank you so much. Yeah, we'll
Yep.
definitely distribute that. And there's another question here about how to build trust with communities after generations of damage has been done. So Cece, I'll open that up to you, or Karan, or Jeanette, anyone who might have some interesting responses. I'm sure you all have a way to respond to this question.
Well, I'll start first. Essentially, you know, decades, centuries, however much, I mean, it's not going to obviously be okay within a few months or a year, and it's still going to be there. But I think, as I mentioned in the presentation, you have to go into the community and talk to messengers that people actually trust. So I'm going to trust my doctor more than I'm going to trust some random person coming in and telling me this is what I need. I'm going to trust my pharmacist. I'm going to trust, you know, the person who does my hair. I'm going to trust people that are in my life, and more so than I'm going to trust a stranger, especially if that stranger is no one that I see in my community on a regular basis. So I think that actually talking, and this isn't just for like communities of color, this is literally for everyone. If you talk to someone that they can trust, they're going to be more likely, and that's how we're seeing hesitancy in all groups lessening as time goes on. Because when you see someone you know that got the vaccine and they're still fine, walking around, talking, like, you know, they're going to be like, oh, well, maybe this isn't as bad. And so I think when you're dealing with various groups, you know, it makes sense for, you know, like what I said about Hispanic American and Latinos going to like community centers. Well, who do they know at the community center? That's something they probably go to and see on a regular basis. And so they feel more comfortable going there, and it's probably language appropriate as well, as opposed to having to go and have someone, you know, find someone to translate things for you. So it's a matter of just like communities and knowing who the messengers are. And a lot of that is knowing who they are and then funding them. So if you can do both of those things, it's great to know who they are and tell them what to say. But if you don't give them any resources, it's kind of hard for them to go from there. So that would be my.
Great. Really helpful. Thank you, Cece.
I'll add a little bit to just support Cece's point about the trusted entity. I call them the gatekeepers, knowing the gatekeepers in your community, whether it be that person in the community that knows everyone scenario, understanding that you have to become a trusted entity before you can even begin having these discussions. If I'm my mother, she hates when I do this, but I'll do it anyway. She trusts her network. She trusts people that she knows. And if she doesn't, she's going to call me and say, well, who is this? Why are they calling me? What is this about? Should I, shouldn't I? So she's going to go and rely on her network, but using trusted entities. I was sharing earlier, I listened to the AARP session. I think it was last week. It was about, they had a famous gospel artist and they talked about using pastors as a part of the process to engage in vaccinations. And we had people come off mute and share their concerns. But again, knowing that, you know, someone's pastor is engaged in a discussion, and people trust their pastors sometimes when they trust their doctors. So pastors and established organizations in the community. So I'm a member of a Black Greek letter organization, and we have an establishment in the community. People know us for certain things. Partnering is my answer to many, many things in terms of access and working with people, but partnering and learning the community and learning who those gatekeepers are that can help you get entree into the community. Because if you come in with one approach and they're going to look at you and they're going to say, that's not going to work here. You need to figure out what we need and how we operate best.
Great. And then I can just comment briefly from my former local health official experience up until September of last year. All of the changes in messaging, a lot of conflicted messaging, a lot of the politics that have infused their way into the pandemic response have really damaged the credibility of public health and in general. So, as CC noted, the layering, these historical challenges of restoring trust for the healthcare system and public health in communities of color. Now we have all of these messages swirling around that don't necessarily agree with one another. Whatever's going on with that ambulance. Sorry about that. But, the point is to be authentic and to be accountable and not try to save face, but just to acknowledge if there has been a harm that's been, perpetrated by government, local government, just acknowledging like this is what we did based off of the information that we had at the present moment. And we apologize, and we're committed to working together to fix it or to provide a different path or whatever the case may be. I think showing that we're human and that we're doing our level best goes a long way. And then, of course, as Karan noted, like just because someone is a medical professional or we have, we're doctors, we have, letters after our name doesn't mean that the community is automatically going to give us trust. Like it's all about the relationships. So really knowing your communities, for you all at the state, like having your connections directly to the local level is very important, and not necessarily always going with the community-based organizations or institutions that you're comfortable with, but being open to creating new relationships with groups that you may have not worked with in the past, especially some up-and-coming grassroots organizations. Many of them have really stepped up to stand in the gap and help during this pandemic experience. So just being open to developing these new relationships and not being so rigid and all of the red tape that comes with being in government, figuring out a better way. So that would be my recommendations. Thanks.
Thank you so much, Jeanette, Karan, and Cece. Really important information. I would just add one more word, and that's humility. I think that, we need to come into communities and build trust from a position of humility and certainly expertise, but humility is really important. I see that there's one more question here. We're about out of time. So Kathy, commenting about the CDC data on the number of people over 65. We will try and get an answer to that question and provide it with the information that we will provide after this session. We will provide the slide deck, all the great links and resources that were shared in the chat, as well as some of the answers to some of the questions that we didn't get to. And then we will continue to try and improve our guide to innovative practices by including additional information on community health workers where we have them. Please continue to share the information that you all have. We appreciate your time today. Please be sure to visit our website at afphs.tiva.org. Sign up. You can sign up for our newsletter, our age-friendly public health systems newsletter. On that page, we invite you to do that and look forward to seeing you next month on June 17th for our next training, when we will be talking about public health's implementation of the Healthy Brain Initiative roadmap. So we look forward to seeing you all next month, and thank you all so much for being with us today.